Okay. So good morning, good afternoon, good evening to every neurosurgeons around the world, and welcome to our ACNS ISMIN webinars. So today we'll have two chairs of today. The first chair is Professor Sanjay, who is the Director of Disability Reconstruction Center and the Professor of the Department of Neurosurgery of Neurological Institute in Taipei Veteran General Hospital, and Ministry appointed Associate Professor at the National Yang Ming National Jiao Tong University. Our second chair of today is Professor Tsutomu Ishino, who is the Associate Professor of the Department of Neurosurgery of the Osaka Metropolitan University in Osaka, Japan. We have two speakers of today. Our first speaker is Professor Sanjay Behari, who is the Director of the SCTIMST in the Trivandrum and also the Professor of the Neurosurgery of the SGPGIMS in Lucknow in India. The topic of today is surgical decision-making in extensive Petroclival meningioma. Our second speaker is Professor Kasumi Omori, who is working in the Department of Neurosurgery of the Sasso Hospital in Japan. His topic today is direct surgical management of thrombosed giant aneurysm in posterior fossa. For the discussion of today, we have Professor Ezra, who is a professor of the neurosurgery and the chief of Neurovascular and Neuroendovascular Therapy Center, and also working in the Department of Neurosurgery of the Faculty of Medicine or Neurosurgical Aganda, which is in the Surabaya in Indonesia. Our second discussant is Professor Gota Nakayama, who is a consultant hybrid neurosurgeon researcher of the Department of Neurosurgery of the GK University School of Medicine in Tokyo, Japan. And also Professor Hitoshi Fukuda, who is an associate professor of the Department of Neurosurgery of the Kochi University in Kochi, Japan. So since we don't have Professor Sanford here, so shall I hand over the podium to Professor Ishino Sensei?
Yes. Okay. The first speaker is was Sanjay Behari, Professor. Yep. Today's topic is surgical decision making in the extensive petroclival meningiomas. I actually expect your nice lecture. Anyway, we have no time, so please start the presentation. Okay.
Thank you. I just share my slides. Can you see my slides, please?
Yes, sir.
Yes. Okay.
Oh, yeah. So first of all, I'm really grateful to Professor Kato and to the ISMINS as well as the ACNS and of course Professor Raja and to all the neurosurgeons from Japan and Indonesia for this wonderful opportunity that I get. I mean, all the training in my earlier years was basically because of the wonderful exposure I got at Japan. And I'm simply grateful to Japanese neurosurgeons for whatever I am today. I'd like to share with you my, the extensive petroclival meningiomas experience and what is the choice of surgical approach in this particular extensive tumor. So there is one saying which says that when a surgeon knows the trajectory as well as the pros and cons of each approach, even for extensive lesions, the surgical corridors become minimally invasive. So let me take you through the entire thing. So when do you say that this is a petroclival meningioma? The tumor has to be centered medial to the fifth nerve when you actually focus on the clivus and the petrous apex, and that's where you have the petroclival meningioma. And usually the conventional approaches will take you through the lower cranial nerves, the seventh and eighth nerve complex, and through the fifth nerve complex, and then you reach anterior to the lesion. But of course, there are some very innovative approaches which will actually completely ease the approach to the area. So let me first talk about some posterior fossa approaches. So if there is a small or large lesion in anterolateral location in the posterior fossa below the internal auditory canal with intact or serviceable hearing, then the conventional retrosigmoid suboccipital craniectomy is a good approach. So it's a small incision here in the retrosigmoid region, just 2 centimeters medial to the sigmoid sinus, going between the cranial nerves, and gradually you can dissect out the tumor, which is the conventional approach. And you can actually, when the tumor creates space for itself, so when you have this extensive lesion, so usually it will create space for itself, and this is the post-operative image, the retrosigmoid approach, and you can retract the cerebellum and just reach the lesion and excise it. But sometimes what happens is that when you have this irregularity all along the borders and there is extensive edema seen on these tutu-weighted images, and this is the coronal image, when you actually do surgery, then post-operatively also, because of the cerebellar retraction and because of a little bit of microvascular damage to the brainstem, there is persistent edema which causes significant brainstem signs, as has been seen in one of our cases here. So we will go for other approaches also apart from this conventional approach. So if there is a small lesion just anterior to the internal auditory canal, not reaching up to the midline, then you can still follow the retrosigmoid suboccipital craniectomy. But the important thing to do is to do an inferomedial cerebellar retraction. So the approach actually becomes almost reaching the fifth nerve directly, as you would do for microvascular decompression for trigeminal neuralgia. So here you just go directly to the fifth nerve rather than exposing the seventh, eighth nerve complex or the low cranial nerve complex, and directly reach the lesion and excises. And this is a very, very effective approach for smaller lesions in that location. If there is a dumbbell lesion, which is anterolateral in location, which is mainly located in the posterior fossa below the internal auditory canal, with a small extension to the supratentorial extradural compartment and with intact or serviceable hearing. Here, the posterior fossa part of the lesion is intradural, whereas the middle fossa part, which is almost located in the Meckel's cave and just beyond it, is extradural in location. So here, a very innovative approach which has been given by the Chandigarh group, which is the retrosigmoid suboccipital cranectomy with intradural anterior petrosectomy. So this was the lesion given by them. And if you have this lesion, so the tumor creates space for itself, and a little bit of tumor, which is almost accessing the middle fossa, there just a bit of intradural anterior petrosectomy actually gets the entire tumor from the posterior fossa, and this could be a very good approach to actually reach the lesion. Now, if there is a large lesion extending across the clivus midline and into the cavernous sinus, and with serviceable hearing, I mean, if there's an extensive lesion here, then I would recommend that you can perform a post-auricular transpetrous presigmoid approach. And that means drilling of the mastoid process. And this could be combined with the retrosigmoid approach. I'll just tell you the approach. So there was this extensive lesion where you can just drill the entire petrous bone and then reach the tumor before you encounter any cranial nerves, and you are decompressing the tumor from within. And then you create a subarachnoid space, and then the entire tumor comes out through the space that you have created here. So what is the approach? You give a small incision in the posterior fossa here. You expose the small part of the middle fossa, small part of the retrosigmoid area. Then you have the sigmoid sinus and the jugular bulb here. And then you expose the mastoid and make sure that the stylomastoid foramen is completely free, and it is not. Then once you drill the mastoid 8 cells will be drilled, and just go to the semicircular canals because you want to preserve hearing. And then you have the temporal extradural temporal fossa here, and then you have the posterior fossa here, and the superior petrosal sinus here. And once you open the dura vertically along the posterior fossa and horizontally along the middle fossa and ligate the superior petrosal sinus, then you don't encounter any cranial nerve. You directly get to the tumor, and you can keep on decompressing the tumor just anterior to just at the fifth nerve area, and you can see the brainstem and the cerebellum, and then you can reconstruct the entire area. And many people have also recommended a cosmetic mastoidectomy, whereas you just remove or the superficial part of the mastoid and then replace it back so that a deep cavity is not formed at the site of your craniotomy following surgery. Now, if there is a large lesion which is extending across the clival midline and without serviceable hearing, with extension of the tumor to the anterior cavernous sinus and the middle cranial fossa, so you can perform an anterior petrosectomy and you can combine it with posterior petrosectomy. So, or you can combine the Kawasai's anterior petrosectomy with the retrosigmoid approach. So that way you actually go through the middle fossa, remove the tumor from the middle fossa, decompress it completely, then go from the posterior fossa and actually remove the tumor from the posterior fossa also. And therefore you are utilizing the middle fossa corridor, you are utilizing a part of the petrous bone, and you are also using the cerebellomedullary and the CP angle cisterns to actually access this part of the tumor. Now, if there is a large anterolateral located lesion which is extending across the clivus midline, inferiorly attached to the anterior foramen magnum dura or encasing the vertebral artery. Now, this is quite low down, very anterior, and the brainstem is right posterior to the lesion. The cerebellum and the brainstem prevents you from actually reaching the lesion. So you can actually perform a far lateral approach or an extreme lateral transcondylar approach with vertebral artery mobilization. I'll show you the steps here. So this was an extensive lesion, a meningioma, which was right anterior to the brainstem. So as you can see, if you go from one side or the other, you will never reach the opposite side, and the vertebral arteries are also stretched. So you can never reach this point. So and this patient, somebody had tried to go for the fossa approach and was not successful. So there was a small incision here. And once the muscles of the posterior fossa are removed, are actually retracted in a single go, the three layers of muscles, then which includes latissimus dorsi, trapezius, and sternocleidomastoid, splenius capitis, and semispinal capitis. You see the C1, this is lateral, this is superior, this is inferior, and you see the vertebral artery at the lateral 1/3 of the C1 arch going into the foramen transverse area of C1. So once you dissect it out and then you drill the C1 foramen transverse area, then you have the entire vertebral artery in your view, and then you can shift the vertebral artery inferiorly or superiorly and actually drill a part of the occipital condyle and the C1 lateral mass to give you a complete lateral approach to the lesion. There will be a little bit of paravertebral venous sinus plexus bleeding that you have to be a little careful of, but you can see the dura of the posterior fossa and the dura of the cervicomedullary junction. And once you open this, you see the vertebral artery, you see the accessory nerve, and you can see the pica, and you can see the tumor between them. And as you go on decompressing the tumor creates space for itself with CSF drainage. And you can see the cerebellum tonsil and then the brainstem and the complete tumor excision following surgery. So this is a very nice approach to go to anterior lesions. Then we come to middle fossa approaches. And I would say that in my career, I have actually shifted from posterior fossa approaches for petroclival meningiomas to middle fossa approaches. And the best, of course, is the petroclival lesions in the middle and posterior fossae about the internal auditory meatus. So the only disadvantage of the middle fossa approach is that you cannot go below the internal auditory meatus. So here, one important thing is you just do a zygomatic osteotomy, you do a temporal craniotomy, go subtemporal, and then do an anterior extradural anterior petrosectomy, and then cut the tentorium and reach the tumor. So you have the entire middle fossa part of the tumor as well as the posterior fossa part of the tumor. So here was a tumor in a young person with 7th nerve and 8th nerve involvement. and with brainstem signs. This was completely calcified. This is the CT scan, which is showing a completely calcified lesion. And in calcified lesions, it is extremely difficult to mobilize the lesion and actually remove it. And of course, going through the retrosigmoid approach would have caused a cerebellar bulging and caused a problem there. So we went to the middle fossa approach, did a zygomatic osteotomy, and you must remember that the approach to the anterior petrosectomy is from the root of the zygomatic process. That is the point from which you actually access the petrous. So it's not anterior, but at that point. And then you see the middle meningeal artery as you retract and the temporal dura, and that you have to cut using micro scissors, and then you separate the middle fossa dura from the cavernous sinus dura, and you get the exposure of the greater superficial petrosal nerve. And this greater superficial petrosal nerve forms the point of anatomy where the petrous part of the internal carotid artery is. So once you are medial to it, this is the arcuate eminence, and this is the fifth nerve, and this is where the petrous apex is. This is the superior petrosal. This is where the superior petrosal sinus is. So with this part of the bone, if you drill, that is the cavasius quadrilateral. So between the greater superior petrosal nerve, the arcuate eminence, the fifth nerve, and the superior petrosal sinus area, which is the petrosal crest here, when you drill it, and what you see is directly you see the tumor here in the middle fossa, and decompress the tumor as much as you can. Then just open the dura a little, very minimally invasive approach, and then retract the temporal lobe till you see the tent. The part of the tent was torn because of the tumor. This is the middle fossa, this is the tent, and using a subtemporal approach. And then the superior petrosal sinus was cut, coagulated and cut. And once we did that, we have the entire exposure of the calcified tumor from the posterior fossa right up to the middle fossa. You see how much of space you get from the posterior fossa to the middle fossa. You get a significant space here. And then we had to drill the calcified tumor gradually and then crush it and remove it without causing any torsion of the brainstem. And gradually, once we had decompressed enough, then we got a very good plane of cleavage from the fifth cranial nerve and the brainstem. And then we could remove the entire tumor. You can see the brainstem, and fat was packed into the area to take care. And this is the post-operative view. We had gone through the middle fossa approach, and total excision was removed, and the patient had no further problems. Then, if there is a large suprasellar, predominantly anterior temporal, cavernous sinus, and anterior petroclival lesion above the internal artery meatus. Here again, I would say that you can actually use anterior petrosectomy, and you can also do a little bit of anterior clinoidal drilling. You can do it extradurally or intradurally, and you can actually do a little bit of petrosectomy. It will give you the entire approach from the middle fossa to the posterior fossa. So this is an extensive tumor here, which is cavernous sinus, suprasellar region, posterior fossa. And here, so what you can do, this is, of course, you this is from on a cadaveric dissection where I'm showing. So meningohypophyseal band you remove, and then you gradually dissect off the temporal dura from the cavernous sinus dura, so you can see the exposure of the optic nerve, carotid artery, and the third, fourth, sixth nerves here. And then the entire clinoid you can see as a triangle here, which you can actually drill. And once you drill that, then this completely becomes free. And then after that, what you do is you do a zygomatic osteotomy here. This is the root of the zygoma. Do a very small craniotomy, expose the dura here. And before, then you retract the temporal lobe and separate the temporal dura from the cavernous sinus dura from the anterior aspect to the posterior aspect. So the entire thing comes out. And with this CSF drainage, which also comes out with this approach, the entire temporal lobe becomes a little relaxed. Then this is the maxillary nerve, this is the mandibular nerve. So you remove the tumor from the cavernous sinus between the two cranial nerves, and you can see the sixth nerve and the internal carotid artery there. And after you have done that, you just shift your focus posterior to the mandibular nerve, to the cavasius quadrilateral, see the greater superior petrosal nerve. This is a part of the tumor which is exposed there that can be completely removed. A little bit of cavasius quadrilateral is being removed posterior to the fifth nerve. And then you remove the tumor from there. So you've removed the tumor from the posterior fossa, you removed it from the cavernous sinus. You can see the internal carotid artery here. Then open the temporal dura, retract the temporal lobe a little, reach the tentorial edge, see where the fourth nerve is, and then cut the tent along the fourth nerve. And because this is a double layer structure, so you have to cut and you have to coagulate and cut so that there is no bleeding. Come up to the superior petrosal sinus, which is here. And once you cut up to that point, preserving the fourth nerve, it is very important to preserve the fourth nerve. You can see the fourth nerve being preserved here. And then you can see the entire middle fossa, and the tumor can be, and the posterior fossa brainstem you can see, and you can see the tumor there, which has been completely removed. And after that, you can just put a patch and you can put a pedicle temporalis flap to completely stop the CSF leak. So now there were three corridors. One was subtemporal corridor, one was cavernous sinus corridor, and one was anterior petrosectomy corridor, and all of them took us to the tumor. And this is the post-operative view. This is immediate post-operative, little bit of hemorrhage in the temporal lobe, but the patient made an uneventful recovery and was fine here. Now, there is another type of tumor, which is not very little tumor in the posterior fossa, predominantly anterior temporal, cavernous sinus, and anterior petroclival lesions, which are above the internal auditory meatus. And one very nice approach, which has not been used enough, is the half and half approach. What is this half and half approach? Half you approach by the frontotemporal transsylvian approach. So you open the sylvian fissure widely and come via the transsylvian approach. And then a part of the approach will be subtemporal. So the entire temporal lobe will be retracted downwards, and you can actually reach the entire tumor like this. So this was an extensive tumor where you see that the posterior fossa component is lesser and the anterior middle fossa component is more. It is coming right up to the cavernous sinus, reaching almost up to the middle cerebral artery, and coming down here. And here it's very easy to look down using this approach. And here a frontotemporal craniotomy was done. And then the tumor, part of the tumor at the cavernous sinus was removed after exposing the cavernous sinus by dissecting the temporal dura from the cavernous sinus dura. So this part was removed, and this is the internal carotid artery that you see in the cavernous sinus. So the tumor keeps on coming out. There's not any significant bleeding there. And then you go transsylvian, and after you've gone transsylvian, then you open it widely, drain the CSF through the membrane of Lilliquist in the carotico-optic space. This is the optic nerve, this is the carotid artery, and this drains it completely. Then you shift the microscope, the anterior temporal region. There will be a few small anterior temporal veins that you might need to coagulate if they are sufficiently small. And then once you retract the temporal lobe, so you are getting a transsylvian approach by this way, and you are getting the subtemporal approach by this way, and this is the tentorial edge. Never cut the tentorium anteriorly here, because you will get the cavernous sinus and there will be a significant bleeding. Go on going posteriorly till you trace out the fourth nerve entering the tentorial edge. And this is the ambient cistern that you see, that this is the part of the tumor. And this is the internal carotid artery. So you are lateral to the internal carotid artery. And this is the posterior cerebral artery. This is the third nerve. And as you go on retracting the temporal lobe gently, you see the bulged tentorium. This is the fourth nerve, which is entering the tent. You have cut the two layers of the tentorium and also cut the superior petrosal sinus, and you are getting the tumor in the posterior fossa. And as you decompress it, there will be a very good arachnoidal plane between the brainstem, the fifth nerve, and the tumor here that you can easily decompress. And after that, sorry, one second. And after that, you can remove the tumor, and then the entire brainstem becomes visible. And with a half and half approach, transsylvian and subtemporal approach and transtentorial approach, the entire tumor has been removed. So this is a very nice, elegant approach. Now, supposing you have another tumor like this, which is also quite anteriorly suprasellar, anterior temporal, cavernous sinus, anterior petroclival above the internal auditory meatus, a little bit of anterior temporal lobectomy, very small anterior temporal lobectomy also really helps to get to this tumor. So with these minimally invasive, small incisions, you can actually get to an extensive tumor in this location. So for example, this was an extensive tumor, and the angiogram shows that it had its vascularity, and it was supplied by both the internal maxillary artery, and it was also supplied by the internal carotid artery. And then what we did was, so we just did a little bit of temporal lobectomy here. So this is the temporal lobectomy. As soon as we did, this is the middle cerebral artery, and this is the open this sylvian fissure. This is the second nerve, and then a little bit of temporal lobectomy was there. This is the temporal lobe, and we did a little bit of temporal lobectomy. As soon as we did that, we got the tentorium with the tumor attached to it, and then we removed this tumor, and this was the posterior cerebral artery. Brainstem can be seen, and then the entire posterior cerebral artery was traced right up to the basilar artery, and you can see the two branches of the posterior cerebral artery and the superior cerebral artery, and the entire brainstem with the entire basilar artery complex can be seen once this a small anterior temporal lobectomy can be done in the half and half approach. So this is a very, very elegant way of reaching this point. And this is the post-operative image, which shows excision of this extensive region. Of course, endoscopic endonasal transclival petroclival meningiomas can be actually done. So this by Dr. Prevadillo and Karau shows a small lesion. Normally you wouldn't even touch it, but this had started causing third nerve palsy. So they actually went through the endoscopic approach and drilled a little bit of clivus and then removed the entire tumor. So an endoscopic approach to cover the armamentarium is a very important thing. My final case is a case which is very, very extensive. So this was a middle-aged lady who had tumor in the posterior fossa going right up to the brainstem, reaching up to the posterior fossa, going in the suprasellar region, in the cavernous sinus, reaching up to the ethmoids, the sphenoids, and coming up to the middle fossa here. And here we had a combination of approaches where we compartmentalize the approaches into many areas, and also you can say, okay, now I will stage this part, then this part, then this part. So you divide your surgeries into sections, so you can do through all these approaches, you can actually reach the lesion. So I'll just show you. So an angiogram showed that there was partial blockage of the transverse sigmoid sinus. So we did orbitozygomatic osteotomy with a temporal craniotomy here. And then we went extradural, so with subtemporal retraction after frontotemporal orbitozygomatic osteotomy. This is the globe scene. This is the temporal dura. This is the cavernous sinus dura. Then we drilled the temporal base to make it a little flat. And then we did an extradural separation after meningohypophyseal band cutting of the parietal layer of the cavernous sinus from the temporal dura. So this was done, and we could completely retract and cause an extradural exposure of the cavernous sinus tumor. We could actually see the entire thing. Then extradural tumor was decompressed from the cavernous sinus and the temporal base between the fifth mandibular and the maxillary branches. And you could see the exposed internal carotid artery in the cavernous sinus after this part of the tumor was removed. And then you go to expose the fifth mandibular branch at the foramen ovale, and then the dura is opened, a little bit of subtemporal retraction is done. You can again see the entire tumor, and you can open the sylvian fissure to further give you space to see the tumor which is in the suprasellar region. And after you have decompressed it, you can see the third nerve, the fourth nerve, and the olfactory nerve after transsylvian dissection. Then you can remove the tumor from the cavernous sinus here, and you see the anterior clinoid process here. You can see the frontal lobe and a part of the tumor which is just jutting out of the cavernous sinus here. And then by drilling the anterior clinoid process, you can do a transcavernous tumor removal from the sphenoid ethmoidal sinus here. And then you can, after this entire thing has been removed, then you can put some fat there to make sure that there is no CSF leak through the sphenoidal ethmoidal air cells. And after this temporal base tumor removal, then next you go backwards, cut the tent, and expose the posterior fossa tumor, and then decompress the tumor, and then gradually lift it up from the brainstem. And you can see the posterior cerebral artery. This is the brainstem, and the tumor is gently being dissected from the posterior cerebral artery here, and then the posterior cerebral artery and the brainstem following tumor removal, and this is the post-operative view of the brainstem. And just before discharge, this lady was tracheostomized. She was having respiratory distress. She was nearly quadriplegia, but immediately following surgery, she had significantly improvement in her motor power. And you see we got a imaging done at follow-up, and you see that there is a significant improvement. Now she is able to walk. The tracheostomy has been closed. Of course, there is a little bit, the seventh nerve palsy is still persisting, but that's okay. So our entire experience, we have actually summarized it in this article in Neurology India. I request you to please make it, and I just request for just, so what is the consensus on it? So in greater than 50% of tumors, change in growth rates can predict clinical deterioration. So if there is an asymptomatic patient with a small petroclival meningiomas, then you can just follow up with meticulous radiological monitoring. Increased growth rate merits active intervention. It's a large asymptomatic tumor. You can follow up with meticulous radiological monitoring, and increased growth rate merits active intervention. Even with large tumors, if there is no symptom, then sometimes you can just follow up the patient. But if there is a large symptomatic patient, then of course, safe microsurgical resection and of course, adjuvant stereotactic radiosurgery cannot be forgotten. It's a very important point. My last part of the talk relates to 3 or 4 slides related to outcome and the complications of other people. So Dr. Atul Goyal tried conventional posterior fossa approaches for surgery on petroclival meningiomas, and he found that the middle fossa and cavernous sinus components of the tumor could not be resected completely in 3 out of 5 cases because of inadequate exposure. And that is why it is very important to combine middle fossa approaches with posterior fossa approaches. Dr. Manas has given a wonderful classification where you can see the which approach to follow based on its relationship to the internal auditory canal and to the jugular tubercle. So this is also a very nice article. Dr. Natarajan and Dr. Laligam Shekhar has used multiple approaches, as has been mentioned in the talk that I gave. But one important point that needs to be mentioned here is that there were preoperatively significant cranial nerve deficits. There was recovery in a significant number of them, but there were also new onset progression as well as permanent deficits in a significant number of people that we need to always take care of. Dr. Seifert also has talked about early and late major postoperative morbidity of cranial nerves, brainstem ischemia, and cranial nerve deficits as can be seen. And Professor Osama Al-Mufti has also talked about, they have summarized all the cases, and they said that the postoperative cranial nerve deficits, this is the summary up to the point that they had actually reviewed the cases. So almost between 20 and 30% will have some kind of cranial nerve deficit or some morbidity, even when masters are doing all these cases. So in our case also, these tumors were very extensive, as you can see, and we could actually see where it is, where the tumor was, whether it was crossing the midline, whether there was brainstem edema. And of course, then we summarized the entire summary of the entire cases, and we found that when we did that, we also found that there were recurrence progression in 3 of our patients. There were new onset cranial nerve deficits in 11 of our patients, and we could only perform complete gross total resection in 12% of our patients. But there is a significant improvement in symptoms of brainstem and cerebellar signs in our follow-up. That, of course, is an important thing. So to summarize, I'd like to share with you a beautiful comment which Dr. Anil Nanda had made in his editorial on petroclival meningiomas in Neurology India 2015. So he says, petroclival meningiomas resisting the siren song. So sirens were those people who were those women who would lure all the ships to the point of destruction by singing a song in the sea. So what they were saying was that when to take great risks, when to withdraw in the face of unexpected difficulties, whether to force an attempted enucleation of a pathologically favorable tumor to its completion with the prospect of an operative fatality, or to abandon the procedure short of completeness with the certainty that after months or years, even greater risks may have to be faced at a subsequent session. All these take judicial, surgical judgment, which is a matter of long experience. So thank you so much. I'm really honored to be here. And this is one very extensive tumor which can be removed with very small incisions and small approaches, provided you know which approach you should take during surgery. Thank you very much for this honor and privilege.
Dr. Sanjay Behari, I actually surprised your excellent presentation. Now the presentation is open to the discussion. Are there any questions or comments from the discussion?
Okay. Thank you, Professor. I would like to ask some question to Professor Behari. Thank you. Very nice presentation. Yes, Petroclival meningioma is, one of the challenging and I think the most difficult cases in our neurosurgical practice. So I'm very interested with your, experience to treat this kind of lesion. So yes, we know in our experience also we have some complication, even it's only temporary and sometimes with permanent, and also some residual tumor also, yeah. And of course some hemorrhage because of retraction and also cranial nerve, temporary palsy, yeah. But I want to ask a very simple question maybe for I think it's important thing for our young neurosurgeon. First, do you sometimes need for preoperative embolization for some such of a very huge tumor? This is the first question, and the second question is to avoid very great retraction. Do you also use some kind of lumbar drain or drainage to to relaxing the brain?
I mean, both
Thank you.
both the techniques are, I mean, used often, and I say that they could be used by people, but I have not personally used a lumbar drain in any of our cases because they were very extensive lesions, and there is always this possibility of a temporal lobe herniation when you put in a lumbar drain. So we actually, even when you and open, one important thing about the lumbar drainage is that if you actually put in a lumbar drainage, then this should only be opened at the time of surgery when the dura has been opened. Having said that, the problem with the lumbar drain is that we have realized that the CSF drains out from the cisterns. And once it drains out, then actually removing the tumor becomes a little more difficult because the CSF is not there to kind of guide you through. So that's something, so I don't really prefer a lumbar drain. And the important point here is that, when you actually decompress the tumor from one side and make sure that it is away from your neuroaxial structures, then it becomes easy to go from the other side and just dissect it off from the cranial nerves or from the brainstem. So that's this two-pronged approach is a very important approach to actually remove this lesion. Talking about the first question about preoperative embolization, yes, you can actually do the preoperative embolization of the branches from the cavernous sinus carotid artery. That is a very useful tool, and that can significantly decrease the vascularity of the tumor. But usually what happens is that the vascularity of such extensive petroclival meningiomas is coming from the entire dura, coming from the ascending pharyngeal arteries, coming from the posterior fossa arteries, as well as from the middle fossa arteries. But when you actually again use this two-pronged approach, then surprisingly in many of the tumors, the bleeding is not as extensive as you think it will be. And the problem about the whole thing is everything depends on the consistency of the tumor. And if the consistency is soft and it is suckable, or if the tumor can be removed, then I mean, when you combine these approaches, it is very easy to remove it. But sometimes it is not possible to dissect it from the brainstem, and whenever you are getting any difficulty, it is much better to leave a portion of the tumor attached to the brainstem or to some structure than to try to manipulate and take a radiologically perfect image, because that later on causes severe brainstem signs, drooling of saliva from the mouth, nystagmus, severe ataxia, hypotonia, inability to speak, and this persists for even 6 months to 1 year to almost 2 years. So that's really very problematic. It's much better to leave a little bit of tumor, because one has to realize that with such extensive tumors, the microvasculature to the brainstem is also involved. So just by thinking that, oh, I will get an arachnoidal plane is not enough. The microvasculature may sometimes be involved, and that can lead to severe brainstem ischemia or edema, which can be quite disastrous in the post-operative period. And another very important point which I'd like to mention is that we always keep our patients with extensive petroclival meningiomas on elective ventilation. We never just take them to the ward and place them there. They will be kept on elective ventilation for at least 2-3 days, where the intensivists and the neuroanesthetists really help us, and they take care, and then gradually wean them off. Based on their low cranial involvement, we just gradually wean them off. And once we are taking it through the middle fossa approach, the incidence of low cranial involvement has significantly gone down. Significantly gone down.
Okay. Thank you, Professor
Thank you.
Behari.
Thank you so much.
Thank you.
Thank you. Thank you.
Yeah.
Thank you for your comment question. Are there any additional comment or question?
Yes, sir, please.
I have answer. Okay, Dr. Dishold.
Yes, thank you so much, Dr. Behari,
Yes, thank you, sir.
for this excellent presentation on petroclival meningiomas. I have a question. Have you had an experience use of retrosigmoid intradural suprameatal approach, going reverse to the petrous apex, drilling the petrous apex from retrosigmoid pathway?
Yeah.
For the petroclival meningiomas?
Yeah, that I just mentioned it because intradural petrosectomy is a very nice approach for a tumor which is mainly in the posterior fossa, suprameatal, and going a little bit in the extradurally in the middle fossa. So there, an intradural petrosectomy is a very good approach. I don't have so much of extensive experience on it, but the Chandigarh, our PGI Chandigarh group has a very nice experience on that. But I have only 1 or 2 cases where we did a little bit of petrosectomy, anterior petrosectomy. There are 2 challenges there. The first challenge is, the internal carotid artery, you're not very sure where it is in relation to where you're drilling. So that sometimes becomes a problem. And the other important problem is that when you drill a little posteriorly, then you are afraid of the internal carotid artery, and the tumor kind of hides behind the petrous apex. So that becomes very difficult to remove. And if the petrous apex is pneumatized, then it becomes a problem to actually stop the CSF leak. So this is why I would prefer to come from the middle fossa approach and actually remove an extensive tumor, which is both a dumbbell tumor in the middle fossa as well as in the posterior fossa. So that's much easier to look down than to look up.
Yeah, exactly. Thank you so much.
Thank you.
Thank you for a comment or question. Any question or comment? Okay. Yes, I have one question to the Professor Sanjay Behari. You can preserve the fourth nerve in the presentation, the huge petroclival meningioma in the middle fossa approach. But in our institute, sometimes the preservation of the fourth nerve is a little bit difficult because especially in the tumor, contents of the tumor is very hard.
Yes.
So I want to know the tips of the preservation of the fourth nerve.
Yeah. So thank you so much for this question. So the most important thing first, and the most important thing is, please just make sure that the actual approach is at the root of the zygoma, which is quite posterior. When people actually go quite anterior, then even before the fourth nerve comes, they actually damage it. So if you actually you have to make sure that you are exposing the tentorium quite posterior. So when the tentorium posterior, at that point, it is 2 layers clearly visible, and then go into the cistern. And once you go into the ambient cistern, then you will see the fourth nerve gradually going across whatever is the size of the tumor in the petroclival. You'll see the fourth nerve going into the tentorium. Now, once it goes there into the tentorium, that's the point where you have to do a little bit of mobilization of the fourth nerve by cutting the tent a little parallel to the fourth nerve. And don't go too anterior, because if you go too anterior, then the cavernous sinus starts bleeding there, and then it becomes your subbasal cisterns get clogged with blood. So don't go too anterior, just stay a little posterior and just mobilize it a little and put a cottonoid over it. And after that, when and the other important point which people actually forget to do is to actually cut the superior petrosal sinus. So when you cut the superior petrosal sinus, then the middle fossa and the posterior fossa become one big structure. So with that, there is so much of cavity created that you can work from a lateral aspect to get the medial tumor towards the lateral aspect. What most people try to do is they go from the medial aspect and then try to decompress the tumor from there. And that's where the fourth nerve gets damaged. So these are small tips which I think preserves. But of course, if the tumor is actually straddling up to the tentorial edge, then sometimes even preservation of the third nerve and the fourth nerve becomes a problem. That sometimes happens, and you might want to leave a little bit of tumor there along the edge of the tentorium.
I see the posterior side on the cisternal portion is relatively wide.
Yes.
Surgical. Yeah.
Yes.
Okay, I see.
But one important caveat is when you're retracting the temporal lobe, the vein of Labe may be one major vein, or it could be multiple small veins. And if you apply too much of retraction there and the vein of Labe gets damaged, then it will become a big disaster. The brain will start bulging. So that one small trick which I have noticed, just keep the vein of Labe very moist. So once it becomes dry, then it has a greater chances of getting damaged. But if you are continuously irrigating that point, then a little bit of elasticity that you get really helps you in just retracting the temporal lobe a little posteriorly and getting to the edge to actually remove the tumor.
Thank you for your comment. And the second question is your surgical photo is very clear, and the blood is very bloodless surgical field. So
no, I have the entire videos. No, actually, I have videos of the entire thing, but the time did not permit me to actually play the entire video. This is an interesting thing about petroclival meningiomas. The real vascular that most of the tumors are not as vascular as you think they are. Even those tumors which are in the cavernous sinus are not as vascular as you think they are. I mean, of course, there will be a little bit of bleeding, but it's not something which is unmanageable. And another thing which I always tell people in India, because many people will not keep fibrin glue. So please, this fibrin glue is sometimes life-saving. So what happens is a little, put some Surgicel with, make a cotton of that and just dip it in fibrin glue and place it there and then move to the other area, and you will get a significant, hemostasis if the bleeding is the other important thing is you have to be continuously in conversation with the anesthetist, because supposing he says that, oh, over a period of time there is a lot of blood loss occurring, then you please just put cottonoid and wait. Even sometimes you have to wait for half an hour. It doesn't matter. You allow the anesthetist to gradually resuscitate the patient completely, rather than being in a hurry and trying to remove the entire tumor in one go very, very fast, because that may suddenly cause exsanguination of the patient. So because you don't realize that gradually the patient is losing blood, and you actually don't realize it because it's not been a very extensive bleeding throughout surgery. So this is some very important thing. So if you anesthetist says, hey, please hold on, the hemoglobin has fallen and the bleeding parameters are a little deranged, and so please, and the BP is a little lower, then you just put some cottonoid and wait for half an hour. You might have go out and have tea and come back and allow the anesthetist to resuscitate the patient than to be very in a hurry. So sometimes these tumors take even 6 to 8 to 10 hours sometimes to gradually remove the tumor.
I see. The hypotension is a chance of the hemostasis.
Yes, you must stop and allow the anesthetist to take over and allow the anesthetist to actually resuscitate the patient enough. Maybe needs to be brought from the blood bank, and then gradually there's no problem. But if you try to be in a hurry, then with a very vigorous, aggressive, transfusion, there may even be a precipitation of disseminated intravascular coagulation. It's much better go very slow, gently, and you'll suddenly find that cleavages and planes will be created. There's no need to be fast in this surgery.
And final question, in our institute, the indication of the endoscopic and nasal approach for the transcribal meningioma and medial side of the transcribal meningioma. And extensive case, we combine the staged surgery. At first, we detect from the cranial side, and then inner of the circle of Willis is rejected by the endoscopic approach.
Yes.
How do you think about the endoscopic approach or combination of the surgical
No,
treatment?
I know that that is the future of neurosurgery. At some point, endoscopic approach and will become the approach to take. But right now we have two limitations. One is flow seal is so expensive in India that if you use flow seal very regularly, the cost of flow seal will be more than the cost of actual surgery. So that becomes an issue number one. The second important problem is because the clivus is so angulated. So sometimes it is very difficult to stop the CSF leak, even when you do a double layering and then you put all the Hadat flap inside and everything. Still, double Hadat flap also sometimes there is a CSF leak and it becomes very difficult to stop it. And the other biggest problem is that the CSF leak will occur into the oral cavity rather than coming out through the nasal cavity. So then you don't even know that subclinical CSF leak is occurring till the patient develops meningitis and also fungal meningitis. So for that purpose, any extensive tumor, I mean a small tumor, of course, which is dead midline, this could be a nice approach. But an extensive tumor, we would still prefer craniotomy rather than endoscopic approach. But of course, I completely agree that as techniques are improving and as the assistants are becoming as good as the main surgeon, gradually the minimally invasive endoscopic approaches will take over.
Anyway, your craniotomy is also minimum invasive for the brain. So agree your surgical strategy in your country.
Thank you.
Thank you.
Thank you very much.
Maybe any comment from Professor Nakayama? Any comment?
Yeah, thank you for your clear lecture.
Thank you.
And I have one question. What do you think about how do the young neurosurgeon learn to some many barriers, lot of approach?
Yeah.
How they
Dr. Nagayama, thank you for this question. The first very important point is that a lot of cadaveric dissection is extremely important because once you do the cadaveric dissection, then you actually get the nuances of surgery which you would not get in a usual case. The important thing about the cadaveric dissection is it should not be done, say, once in 6 months. When you actually do a surgery and you find that this part of surgery I was not clear about, then immediately within 2-3 days, you should actually go to the cadaveric lab and dissect out that particular part of the anatomy and also read about it extensively. And that really helps in ticking it through. The other very important thing is that many of the youngsters, they are very keen to do total excision because they want to show, oh, we have done very good work and total excision, and that causes a lot of problems. So in the early stages, a stage surgery using conventional approaches is a very simple and a nice way to do it. Like, for example, you can actually do a little bit of anterior temporal lobectomy. You can go subtemporal. Then you can go by the retrosigmoid route. This is something which everybody has learned to do. You can leave the tumor which is in the cavernous sinus and give radiosurgery to it. Right. So then as experience grows, and if the tumor is soft and easily suckable, then you become more and more aggressive.
Yeah.
So these are some points that first go by the conventional approaches. You go by stage surgery. So you can first do middle fossa approach to the point that you can do, then go by the posterior fossa and do a little bit of it. And whatever is left, you can give gamma knife and remove the tumor. And that way, the patient remains intact. And with every case that you do, you become more and more experienced. And then you can combine both the stages into a single stage. And of course, taking expert help in your initial cases is a very important aspect of the whole thing. The other surgeon who's experienced can actually join up with you and help you remove the tumor and recognize the danger areas. I think that is a very important aspect of the learning process. Surgery is a lifelong learning, I think. And the other important aspect is, with endoscopic approaches, the ENT surgeons are very, very good and they are very experienced. So just having ENT surgeon help you is a very, very important advantage for each one of us, because the ENT surgeon is very comfortable with the anatomy and we are more comfortable with the intradural anatomy. So a combination of both these knowledge bases really helps the patient. And then finally the repair, if it is done in combination with the ENT surgeon, really decreases the chances of CSF leak, because they have techniques to kind of stop the CSF leak in an endoscopic approach. So these are some of the things which
Thank you.
Thank you so much.
Thank you.
Just a very short question in the Q&A box. So do you think any role of endoscopy in most of the tumor that you discussed?
Yes. So if say, for example, you are going by the retrosigmoid approach or you are going by the pre-sigmoid approach, and you find that there is a suspicion of a tumor which is anterior to the brainstem, medial to the third nerve, which you cannot see by the approach that you're using, then you can actually use an endoscope to visualize that area to make sure that whatever is the resectable part that you can easily resect can be taken off. Likewise, supposing you're going by the middle fossa approach, and the lower limit of the middle fossa approach is the internal auditory meatus. If you try to go below the internal auditory meatus using a middle fossa approach, it is very difficult to do that, and it can cause significant cranial nerve deficits. So there, you can place an endoscope to just see whether there will be a tumor which is posterior to the internal auditory meatus and which is not accessible through the middle fossa approach. And in case there is tumor, then you can actually combine the middle fossa approach with a little bit of retrosigmoid suboccipital craniotomy to actually take care of that tumor. So there, endoscope can really, really help you in your thing. And of course, we've already discussed the fact that if you go via if there's a midline tumor, you go decompress the tumor using the midline approach, and then you come from a lateral approach and separate it from the brainstem, from the cerebellum, and from the cranial nerves. That can also be done. So, of course, there is a lot of advantage of doing a picture-in-picture approach where an endoscope can be combined with a microscopic surgery.
Okay. Professor Fukuda, do you have any question or comment?
Yeah, many people are very interested in this topic, so I'm just a little bit afraid of the time limit. But yeah, I only have one question to Dr. Behari, and it's a nice presentation, and I want to talk about the cavernous sinus origin meningioma, which is very extensive to the petrous region posteriorly and lateral to the middle fossa, as well as the medial to the suprasellar region. So I had once such a case last month, and she had a very just a little symptoms like temporary facial numbness and a little visual field disturbance, but the tumor was very huge. I just took out the tumor from the transmastoid to the posterior fossa, and then just do the front temporal extradural approach to take out the middle fossa, and then the endoscopic guides that took the suprasellar part from the endonasal. But I didn't touch the cavernous sinus at that time. My question is, in your presentation, you presented similar two cases, such as an extended and cavernous sinus origin meningioma. In your video, in your presentation, you took out the intraoral cavernous tumor first, at that time. So what is the advantage of the taking out that tumor first from the cavernous sinus, and what is the possible disadvantage in terms of the cranial nerve or postoperative palsy?
So thank you for the question. The first thing is when you actually, it's all extradural. So any bleeding which is occurring is also occurring extradural. And when you are going from the middle fossa approach and working between the mandibular and the maxillary nerves and removing as much tumor as you can from there, then a lot of your tumor, which is in the posterior fossa and which is actually causing brainstem compression and causing cerebellar compression, actually starts being dissected off extradurally. The part which is coming from the intradural portion to the cavernous sinus, medial wall of the cavernous sinus, all that kind of starts coming in your view. And once you do that, and when you enter through the intradural portion, then you find that the cerebellum has become lax and you are getting a better plane of cleavage. That's one. The second important thing is I completely agree with you that there is this apprehension that if third, fourth, sixth nerve get involved in the cavernous sinus, then that is akin to losing the eye. This is 100% thing. But what I have realized is that if you are working in the posterior part of the cavernous sinus and not coming to the anterior part, you are not even coagulating the anterior part, then, the third nerve, the fourth nerve kind of shifts medially. And the sixth nerve, usually with the internal carotid artery, is shifted medially by the tumor. So then when you are going from a lateral aspect, then and from a posterior lateral aspect of the cavernous sinus, then it is possible to remove a significant portion of the tumor without causing any permanent cranial nerve deficit. Of course, supposing a tumor is actually infiltrating into the fourth nerve tentorium edge, then of course fourth nerve is gone, and that will mean that the patient, while looking downwards and medially, there'll be a little bit of a problem there, or reading will become a problem, there'll be diplopia there. Or if a tumor is going into the anterior cavernous sinus and involving the third nerve there, sometimes what happens is that the third nerve gets stretched. In one case, the third nerve was completely stretched by the tumor, which was like that. And I almost cut the third nerve because I thought this was a tumor. And then and then suddenly I realized, oh my God, this is third nerve. And then, with the electrophysiological stimulation and all that, oh, this is third nerve. So then we had to gradually dissect off the tumor. And many of these patients who have a transient cranial nerve palsy usually improve significantly following surgery. But I completely agree with you that if it is the consistency of the tumor is such that cavernous sinus dissection is becoming difficult, then it is much better to leave it there and give stereotactic radiosurgery than to have the patient suffer from multiple extraocular movement deficits, which is actually like losing the vision of that eye, because that eye becomes useless, the fixation goes. So I completely agree with you there, sir.
Okay, thank you very much. So next time I will just take out the posterior cavernous sinus part, so it will be nice to decompress the cerebellum and the brainstem before opening the dura. It's a nice comment from you. Thank you very much.
And when you're doing that, how do you know when your anterior limit is reached? What happens is when you're actually coming to the anterior aspect, suddenly there will be a brisk venous bleeding coming from the anterior cavernous sinus. So you know that now you have communicated the anterior cavernous sinus with the posterior cavernous sinus. When a tumor-filled cavernous sinus will never bleed. But as soon as you reach a part of the cavernous sinus where suddenly bleeding starts, that means now the tumor is out from the cavernous sinus to the extent that you want. So this is also...
Thank you, Professor Fukuda and Professor Sanjay Behari. It's a time to close this chain. So I return to the ledger. Please continue to move on the next case.
Thank you so much. It was a real honor and privilege. Thank you.
Thank you, Professor Sanjay. So maybe we can proceed to our second lecture by Professor Kasumi. And Professor Ishino, if you don't mind, you can continue. Please continue to chair the second session as well, as Professor Stanford is not available today.
Yeah.
Is that okay for you, Professor Ishino?
Yeah. Okay. I continue the chair. Thank you. Next presentation is the direct cycle management of the thrombosed giant aneurysm from the Professor Kazumi Omori. Professor Omori is the run the skull-based surgery. You know the Professor Fukushima. So I actually expect that this presentation. Please start the presentation, Professor Omori.
Thank you, Chairperson. So, do you hear me? So, is it okay?
Yeah.
No problem.
We can hear you.
Yes.
Okay. Let me start. So, I'm Kazumi Omori from Osaka, Japan. I'm very honored to have a presentation in such a great conference in ACNS. Today, I would like to present our experience in direct surgical management of thrombosed giant aneurysm in posterior fossa, focusing on lessons learned from skull-based techniques. This slide shows a Petroclival meningioma, not so big one. As you can see, the tumor itself expands the cistern and provides a natural working space. Therefore, a standard anti-transpitural approach is sufficient for safe resection. These are pictures of actual surgery. At first, middle fossa drilling to expose the durable internal auditory canal. Next is tentorium cutting. Trochlear nerve runs close to the tentorial edge, so we have to care. After cutting the tentorium, tumor can be identified beyond the fifth nerve. It was not so difficult for total resection. I would like to highlight a key difference. Unlike tumors, vascular lesions do not provide surgical space. In these cases, we must create the working corridor ourselves. Therefore, skull-based approaches such as the transpitural approach become essential. This is a photo of cadaveric dissection of middle fossa for anterior transpitural approach. This area we call middle fossa rhomboid, which is defined GSPN, posterior border of V3, superior semicircular canal or arcade eminence, and petrous ridge. Anterior transpitural approach should be drilled this rhomboid to expose the durable internal acoustic canal. The internal carotid artery runs just beneath GSPN, and the cochlear lies just right around the triangle. So we should start to drill from the red circle at first. So this is the final view of the anterior transpitural approach. The door of the internal auditory meatus is exposed. Now we can see the inferior petrosal sinus and the clivus like this. Next, I will introduce mastodectomy. At first, landmarks as outer triangle should be defined, which compose of posterior point of root of zygoma, asterium, and the mastod chip should be confirmed. In next step, the cortical bone of the outer triangle is drilled out to expose the dura of the posterior fossa and the sigmoid sinus. Next step is opening the mastoid antrum, which is the largest air cell of the mastoid. In enlarged view, lateral surface of lateral semicircular canal, incus, and the malleus head can be seen like this. Next, the ceiling of mastoid antrum is unroofed to expose temporal tegmen. So this is the final view of mastodectomy. The cancerous bone around the semicircular canal is drilled until exposing the tube-like structure of the cortical bone like this. After dural incision, basilar artery can be visualized perpendicular to the surgical field like this. Let me present some representative cases. This is a patient in his 80s who suffers of a arachnoid hemorrhage. 3D CT shows a giant aneurysm located in the mid-basilar trunk. In this case, we performed the direct clipping via a subtotal petrosectomy approach. So let me show you a surgical video. Following mastoidectomy, we proceeded toward the middle fossa and drilled the rhomboid area to expose the dura of internal acoustic canal. Translab approach was added to allow posterior transposition of the facial nerve. After sacrificing the cochlear nerve, the facial nerve was rerouted posteriorly. The tentorium was inserted with careful attention to the trochlear nerve, followed by opening of the posterior fossa dura and Meckes cave. And the abducens nerve was identified up to Dreyer's canal, and the basilar artery was secured inferior to it. The aneurysm was visualized anterior side to BA, and the neck was carefully dissected. Finally, complete neck clipping was achieved using a straight clip. So this is a post-operative 3D CT shows the aneurysm was clipped completely. Next case, a man in his 50s had progressively enlarging thrombosed aneurysm of the right vertebral artery. MRI shows aneurysm compressing brainstem. We planned vertebral artery trapping. However, a single approach was not sufficient. Therefore, we used a posterior transpetular approach for the distal segment and the transcondylar approach for the proximal segment. Trapping was achieved with this combined strategy. Let me show you the surgical video. After performing a right-sided mastoidectomy, we proceeded to the transcondylar approach. Through the lower cranial nerves, the vertebral artery and the aneurysm were identified. We then switched to the posterior transpetular approach, where the right vertebral artery was secured and a clip was applied just distal to the aneurysm. After that, we return to the transcondylar approach again and apply the clip proximal to the aneurysm. Thus, complete trapping was achieved. Post-operative MRI shows no sign of ischemic change. The next case also involved the thrombosed vertebral artery aneurysm. As in the previous case, trapping was considered. However, because the right vertebral artery was hypoplastic, we attempted reconstruction of the left vertebral artery in addition to trapping. This slide illustrates our surgical strategy. The aneurysm of left vertebral artery was displaced toward the right side because a single approach does not provide adequate access. We chose a combined strategy. At first, the proximal segment was approached via transcondylar approach. Next, distal segment was approached via opposite side, via right posterior transpetular approach. and reconstruction was performed using a radial artery graft from the right external carotid artery. This combined approach allowed both trapping of the aneurysm and reconstruction of the vertebral artery. Let me show you the surgical video. We first performed the left transcondylar fossa approach. Without opening the dura, we moved to the contralateral side. The right external carotid artery was exposed and secured, and right-sided mastectomy was performed. We returned to the left side again and opened the dura. The vertebral artery, pica, and the aneurysm were identified. A proximal clip was applied just distal to the pica. Pica's flow was secured by Doppler flowmetry. We then moved back to the right side and opened the pressing dura to expose the left vertebral artery. The left vertebral artery was divided distal to the aneurysm. Using a radial artery graft, a bypass was created from the external carotid artery. During reconstruction, flow from the right vertebral artery was maintained, so there was no concern for ischemia. Postoperative MRI shows no sign of ischemic change. Postoperative angiography shows left VA and basilar artery is delineated through the radial artery graft. This is the last case. The patient developed the progressive cerebral infarction due to thrombosed giant aneurysm at the PA-ICA junction. Direct clipping was performed via posterior transpetersal approach. So let me show you the surgical video. After a left-sided mastectomy, the proximal dura was opened. The aneurysm was exposed above the gross pharyngeal nerve. The neck was carefully identified, and 3 parallel clips were applied with preservation of the basilar artery. Complete neck clipping was achieved, and 3D CT shows. That's it. In vascular lesions, space is not given. It has to be created. Thank you for your attention.
Thank you for your wonderful presentation, Professor Omori. Now presentation is open to the discussion. So let's start the discussion. Any question or comment, Professor Fukuda?
Dr. Ichinose, I am called by the ward, so please let me talk first. Otherwise, I may be called sometime. So, Professor Omori, thank you very much for your presentation. And I'm interested in the case where you made a radial artery to right, deviated right vertebral artery. And when you're doing the parent artery occlusion with that huge aneurysm, and I may have missed it, but can you just close the right vertebral artery with the aneurysm, and you already spared the vertebral artery to pica pathway? So
no, I don't. I never touch the right vertebral artery. Never touch. Just only the left vertebral artery.
Sorry, the left vertebral artery and the right vertebral artery was patent.
Patent, yes.
Patent, and then the left vertebral artery is closed, and then the distal part was cut.
Yes.
Cut. But you can only just sacrifice left vertebral artery and that's it. Why do you think you need a bypass to the right side?
Because the right side vertebral artery is hypoplastic.
Hypoplastic. Oh, I
Yes,
see. I see. So the diameter was totally different.
Yes.
Very hypoplastic. So you
Yes,
have
yes,
to
yes.
reconstruct that
Yes,
dominant vertebral
Yeah,
artery.
yeah.
Okay, I understand. Thank you very much.
Thank you for question or comment. Okay. Any question or comment? Person Nakayama, do you have any question, comment?
Yeah. Thank you. Professor Omori, thank you for your clear lecture and clear operation video.
Thank you.
I have some question. The first has introduction of flow diverter as an endovascular device changed your surgical strategies?
I asked some endovascular surgeon, but it's very difficult for thrombosed one.
Yeah.
Thrombosed giant aneurysm is not so easy to by using a flow diverter or other instrument.
Mm-hmm.
So I have to do that.
Yes, and what is your opinion on the vasovasorum for the thrombosed giant aneurysm?
It's a very difficult problem, so maybe we cannot decide in our operation time. We cannot decide it's okay or not. Just solve the vasovasorum problem. So just we have to decide to which. So
yes,
it's very, very difficult.
Yes, I think so. And sorry, last question. In the case of giant thrombosis aneurysms, unnecessary if there are no symptoms.
In my experience, there is no cases of no symptom. So all cases have some symptoms, or some dysphasias or other symptoms. All patient has a symptom. So if the patient has no symptom, I maybe wait.
Yeah. After your surgery, how about the patient's symptom?
No change. Gradually getting better, recover all patients.
Thank you so much.
Yeah, thank you.
Yeah. Next, Professor Ben, do you have any comment, question?
Yes, just a short question and wonderful lectures, and Professor
Thank you.
And really impressive strategy for the open vascular surgery. I would like to ask about for these giant thrombosed aneurysm. Do you usually cut open the aneurysm to remove the thrombus after trapping, so to relieve the mass effect, or do you just leave it there after trapping it?
Yeah. So far, I never opened an aneurysm, but I prefer. I have no evidence to cut the aneurysm, but some doctor who I trust teach me that just cut the aneurysm to the touch the CSF. You understand what I mean? It's getting better, but I have no answer. I never experienced.
Thank you so much.
Mm-hmm.
Yeah, I have a small cases of the thrombosed giant aneurysm, but if we completely trap the aneurysm, the aneurysm gradually shrinking and relieve the mass effect in the follow-up period. So I have no experience of cut of the aneurysm, but the patient get a recover or maintain the symptom. Any other question or comment?
Yeah, may I ask a question? Yeah.
Yeah.
Yeah. So very nice presentation, Dr. Omori. I just wanted to ask one thing. There are two types of giant thrombosed aneurysms. One where there is partial filling and one where there is complete thrombosis with mass effect. So would your strategies be different for those cases or will they be the same?
Thrombosed?
Partially thrombosed and completely thrombosed. Okay.
And
completely,
one is partially filled.
The completely thrombosed?
And partially filling. So on angiogram, small amount of the proximal portion is filling. So will your strategies be different or exactly the same?
So one angiogram, small amount of the. Sorry, I don't understand.
So
the Professor Sanjay Behari told if the aneurysm, we can see the neck of we can secure the neck of the aneurysm. So we consider the clipping or trapping. Okay, Professor Behari.
No, so if there is an aneurysm where CT angio shows that the entire aneurysm is completely thrombosed, large aneurysm causing mass effect and thrombosed, and one aneurysm where large aneurysm thrombosed, but proximal part is filling. The
proximal part is filling.
Yes.
But partial thrombose, what do you mean?
Yes. So one is completely thrombosed, one is partially thrombosed, both giant.
So what should I do? What should I do? It's so very difficult.
In such a situation, if the neck is remain, we have a chance of the neck gripping to the aneurysm. I have one case, the large progressing vaginal SCA thrombosed aneurysm, the neck was remained. So in such a case, I use the anterotemporal with the oculomotor transposition, and I could get a surgical space, and I inserted a straight clip on the neck. But the completely thrombosed aneurysm, we cannot do it. So in the surgical findings, based on the surgical finding, finally we should decide which is the best way for the patient.
Yes. It's up to the case.
Thank you.
Any questions or comment? Okay. Professor Fauzi?
Professor S or Professor?
No, I have no question there. Thank you.
Yeah. Any other question? So
if there's no question, then I think it would be coming to the end of our webinars. So any final remarks from Professor Kato?
So much, and the two cases are very, very interesting. And anyway, we need complete the anatomy is very basic and very important. and also the surgical skill. Of course, I work together with the Omoi sensei sometimes. He knows very good the anatomy and also a very nice skill. Of course, I saw the Sanjay Behari, the surgery, when I visited in India. And since at the time, so many years has passed, but Sanjay's technique improved a lot. So I think that too is a very difficult case, but I think it's very, very important for the open surgeon. Nice discussion. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you so much. On behalf of the Educational Committee of the ACNS, and I would like to thank our chair, Professor Ishino, for the great chairing of this section. Today, we are having a really impressive lecture with difficult pathologies, with the skull base on Petroclival meningioma by Professor Sanjay, and also difficult giant thrombosed aneurysm in posterior fossa by Professor Kasumi. So I really appreciate that your expertise and share it among us. And I have some announcement and just before the end of the lectures. So this is I'm asked to share this during the ACNS meeting in Mumbai. So we'll have the Fujita Health University alumni cocktail section on the 1st of August in 2008, in 2026, and during the ACNS Congress in Mumbai. So please feel free to join us, and also the ACNS mapping. And also we are having 2 meetings.
Please share the flyer.
So okay, sure. And can you all see this flyer?
Yeah, it's fine.
Yeah. Yes. So this will be in Mumbai in the 1st of August, and at the 7 p.m. So it will be during the ACNS Congress in Mumbai. And I would also like to share 2 events of the year. And so the first one is the ISMIN Congress, which will be combined with the Fossa Hospital Congress, and combine the ISMIN, which will be in the September of the year. So it will be in the Fossa Hospital in Shanghai in September. So they will be combined with the ISMIN Congress at that time. Another important meeting would be the 4th World Young Neurosurgeon Congress in Hong Kong. Will be at the 30th October to the 1st of November. So there will be the 2 important events of the year for the ACNS today, besides the ACNS Congress. So with that, I would like to end the section, and I would like to really thank you so much for your participation. Maybe any final remarks from Professor Ersma or Professor Kato? Any remark on the coming meeting?
Thank you, Dr. Ben. Very nice webinar today, and also thank you for your announcement of the very important meeting this year. I would like to share this announcement to our young researchers in Indonesia. Thank you very much.
Maybe you can make some flyer for your Congress 2027, right?
Yeah, next year. Thank
So
you.
is it the WFNS?
Yeah,
Congress?
WFNS World Congress. Yeah.
Congress, okay.
Yeah,
In
thank you.
summertime.
Yeah, thank you.
Thank you very much. Thank you.
Thank you so much. Hope to see
We all
you.
visit your place. Bye-bye.
Yes.
Bye-bye.
Thank you so much.
Thank you very much. Thank you.
Thank you.
Thank you so
Roger.
much.
See you again.
Thank you so much.